it is clear that, when you heard me speaking in the morning, we were all talking very brightly about how T3, T4, N2 have beautiful pathological response, etc. The story does not end there. Story does not end there. If you look at the same patients after 3-4 years, you will see a majority of them has failed in many ways, and one of the significant ways of failing is in the liver. Now, that has not changed really. In spite of a lot of advances, the 5-year survival of, as you have seen, of higher risk, locally advanced colorectal cancers have not improved significantly, despite of whatever treatment you do. And a significant number of them will actually fail in the livers. Now, I'm not considering this focus is only on the liver metastasis, and we will see that a recurrence or up to 70 to 80% of the patients, they will have some kind of a liver metastasis in 3 years' time, and a significant number of them will be, having experience of relapse. Now, therefore, having a coherent strategy for addressing the liver is very, very important. And now, why is it so? Why is liver different compared to, let us say, a bone or something else? Because a low volume liver metastasis in colorectal cancer, if treated appropriately, is almost like a non-metastatic disease. I would say almost like, it is not quite like, almost like. Unlike other sites where the lungs, etc., the things could be different. And therefore, there has been an approach to treat them more aggressively than having a metastasis elsewhere. Now, when a patient presents with a resectable metastasis, one has to first look at an option of operating the patient. Now, surgery is definitely the thing that you should all look at. Having said that, it is not so easy for every patient to be selected for surgery. You have to see whether they are clearly ulcer-resectable or not. If it's, for example, if it's a single less than 2 centimeter liver met, then there is not much of a question asked. But if it is more than that, then many prefer to give some sort of a chemotherapy, as we heard now, to downsize it and make the surgery more feasible. If it is a borderline resectable, definitely in that case, an intensive chemotherapy is called for to make it resectable. If a patient is not resectable, it is only then you should think of other local therapy options, be it RFA, be it TACE, be it SBRT, whatever. Now, this remains the fundamental state that you should always look at all these patients whether they are resectable or not. Now, as I said, the best treatment remains for them the metastatic. And as I told that, the incidence of metastasis is almost 30% at 1 year, and 30 to 70% patients will develop metastasis over time. And once you have a metastasis, the median survival is only 6 to 12 months, and it is 30% at 1 year, and at 4% and 1% at 4 years. Practically no patient will be alive after 4 years if they have metastasis. Now, while surgery is the most recognized method for treatment and chemotherapy goes with it, there are other local therapy options when the surgery is not upfront possible, which are TACE, RFA, and SBRT. What are the different pros and cons of these different techniques? Now, surgery provides you the best long-term benefit. Every attempt should be made to make this patient resectable. But when you are not, then what are the options? Because actually only 10% of the patients that you see are upfront resectable when they are at presentation. So what happens to the rest of these patients? One of the options is definitely tumor ablation, by which I mean to say RFA or TACE. Now, the challenge with TACE or RFA is that the selection criteria are very, very strict. I was discussing with some people during the lunch table, and I will repeat that one here. There is a size criteria, of course. Size is one of the key criteria that you decide when you are taking up a patient for either RFA or microwave, which is by and large similar to what limitations have in radiation as well. But there are some other difficulties. First of all, you have to understand this. RFA or microwave is essentially an invasive procedure. Now, when there are invasive procedures, you always have an additional risk of development of toxicities, complications. That is number one thing. Number two thing is that when you have a tumor which is just under the capsule, subcapsular tumors, they are not the best cases for RFA because capsular contraction can lead to a lot of difficulties. Second thing is that RFA works by creating a ball of heat around the RSA tip, and that heat is the heat that kills the tumor. Now, if a patient's tumor is close to any of the major vessels, half of the heat is washed away by what is called as a heat sink effect. And that reduces the efficacy of RFA, and therefore RFA becomes not so great option when it is next to a major vessel. And also when you have a deep tumor, the chances of missing the RFA because RFA is usually guided by ultrasound, and a deep liver tumor may not be so well visualized by the ultrasound, and there are chances of missing the target. So given this constraints, one has to keep in mind that a case selection is very, very, very important. IR department, I don't know how many are having the access to IR departments here. Anybody in the IR department who acts, or anybody here who acts in close tandem with the interventional and radiology department here? Nobody's here? Okay, I can tell this then. Great. IR department, they don't too often come to discussion with a lot of other people. So they often tend to have little less understanding of a tumor as a process, and they often see the things as a technique. Now, this is a challenge because many of the IR departments are functioning in India as standalone centers and not a part of an oncology center. And therefore, they fail to understand this. And that is the reason we see a lot of IR failures. But that in our hospital, we have minimized it by making our IR team integral part of the MDD. So whenever I see a situation like this, both the IR team and us sit down and discuss the pros and cons to make sure that you are not choosing a case which is a prone to failure case with IR. So that is very, very important, that you have to choose a very, very selected cases. Now, having said that, in terms of efficacy, RFA is practically almost as good as surgery. So if a patient is eligible for surgery, surgery is the option. If the patient that is not eligible for surgery but eligible for RFA, RFA is the option, and radiation comes to a patient when RFA is not eligible. That is something you have to understand. In terms of micro-F, it is supposed to be equal to RFA, but there is no large randomized trial to show that. A lot of phase 2 data show that they are equivalent. Our experience is also similar. In terms of the utility of TACE, TACE has not been really shown to be of the high quality as RFA. Therefore, we tend to, once a patient is not RFA-able, we tend to offer SBRT for them. That is a practice. Now, this could typically be different from different institution to institution and different because of the availability of skills. SBRT is not easy, RFA is not easy. So you have to choose a modality where you have the best of technique available. Don't adopt technique done by a person who is not very good at it. Coming to radiotherapy, the key thing about radiotherapy is that the hepatocytes are very, very sensitive to radiation. Now, while this is true, you have to also understand that what you are treating here in a metastatic colorectal is not a pure hepatocyte, but a disease whose origin is in the colon or rectum. Now, therefore, when you do SBRT for hepatocellular carcinoma, the requirement for dose is not as high. We typically take 50 gray in 5 fraction as our watershed dose. In other words, we try to achieve a 50 gray in 5 fractions for a hepatocellular carcinoma if all things are good. If it is not good, we come down by doing a toxicity analysis on the residual liver and show you how to do it. And we can come down even up to 35 gray. As long as we are able to deliver 35 gray in 5 fractions, we will still consider the patient suitable for SBRT for HCC. However, when it comes to a liver metastasis from a colorectal, we take 50 gray in 5 fractions as a lower end, and if permitted, if the residual liver permits, we will go to a dose higher than that, which is what exactly you saw in the patient that Dr. Vamshi had shown, where there was a residual after a microwave, we have given 60 gray in 5 fractions. So this is the key thing to remember, that a metastasis requires much higher dose than a hepatocellular carcinoma. And the only thing that holds us back is radiation-induced liver disease. Now, radiation-induced liver disease is basically a non-icteric rise of the liver enzymes following radiotherapy. Now, fortunately, and knock on wood, we see very less of these days. That is because we have understood the whole process of RILD, and we know certain parameters in the radiation planning, if strictly followed, will reduce the chances of RILD significantly. Now, when you compare the incidence of RILD in liver, HCC versus the RILD of treating of metastasis, there are 2 factors. One factor is that often in the metastasis, you are treating more tumors as compared to hepatocellular, where you are treating a smaller tumor most of the times, actually, not always. That is one reason that your liver dose could be higher. On the other hand, also the second thing with the metastasis is that your dose is also higher as compared to HCC. On the other hand, HCC often has got compromised liver function to start with, which is not usually the case for a metastasis. So there is win some and there is lose some. But the objective parameter that tells us that whether the patient is going to have a liver RILD or not is going to be determined by technical volume, which I will tell you later down the line. And as I told you, the same thing, the RILD is a non-icteric rise of the liver enzymes. It can happen within 2 to 4 months of the thing. There is no treatment for RILD. If the patient gets better by himself or herself, good, otherwise the patient will die. Therefore, it is absolutely important that you make your measurements in such a way that the patient does not have RILD. Now, SBRT is essentially a method of delivering the high dose external beam accurately to a target. That's all. We can use multiple beams depending on the type of the location, etc. This is just more and more time we are actually using rotational fields, what we call as a volumetric arc or rapid arc as variant calls it, and you have to have a relative sparing. The key thing in liver metastasis SBRT or any liver SBRT is obviously the delineation of the target. Now, I thought that this is going to be a very mixed audience, which is why I have not gone deep into the technique of it. But I will just tell you briefly. We need to immobilize the patient's movement, reduce the movement of the liver as much as we can. And as long as the liver is not moving more than 1 centimeter craniocaudally, you should attempt. If the liver is moving more than 1 centimeter craniocaudally, it becomes very difficult because you have to expand your volume to cover the movement, and therefore your normal volume becomes too much. Therefore, it has to have either abdominal compression, deep inspiration, breath holds. There are many techniques. You can also use a 4D CT, you can use a dynamic CT scan to capture that. You have to have the radiation planning scan should be a triphasic scan. You should not do a normal scan. You have to have a triphasic MRI, which has to be fused with the radiation planning scan to do the volumes, and you have to have a perfectly developed motion management system where you deliver the dose. Now, as I told you, the same thing, that you have to have immobilization, compensation for respiratory movement, imaging systems, and delivery systems. And this is a classic example that you can see here. It can be delivered with different kinds of machines. This is an old, Novalis CyberKnife. There is a standard linear accelerator. There is no difference in the outcomes because all these equipments, they ultimately deliver a 6 megavoltage photon. There is no difference in the outcome irrespective of the machine that you are using. Don't believe any of the vendors if they tell you CyberKnife is better, TrueBeam is better, they are all same. What is different is, however, that the ergonomics are very, very, very different. I have not used CyberKnife often, and I will be struggling if I have to use CyberKnife. Similarly, a doctor who uses CyberKnife all the time, that doctor will be struggling to use a TrueBeam. So therefore, you have to be master of your tool. If you are not a master of your tool, irrespective of how bad or good the tool is, you will not be able to deliver. And it is important to have an image guidance thing. I mean, I'll be very happy. I've been talking with a lot of people. I'll be very happy to hold a separate meeting completely for liver SBRT. Now, The question is what we call as a oligometastasis. The reason behind why SBRT in liver metastasis is now common is because it is the idea that oligometastatic patients are better than a grossly metastatic patients, and if that metastatic site is treated aggressively, they might give you as good a result as not having it. For example, SBRT can provide local control in the range of 62 to 100% and 2-year local control of 45%. Now this is almost as good as what surgery can give you for a select group of patients. The criteria for selection will be is what we call as a suitable. In the suitable one, we typically take less than 3 lesion number, diameter is between 1 and 3, and the distance from the ORs at least 8 millimeters. And they should be having good child liver function, and the free liver volume should be 1000 cc. And you have the cautionary. So this is a very, very important thing. 700 cc of liver should not receive more than 15 gray of dose. If, as long as you can achieve this, the chances of RILD is not there. Now this is a big line for us. If we are not able to achieve 700 cc receiving 15 gray, and to achieve that I have to bring my dose down below 50 gray, then radiation wise this is not a good case. I will not be happy with this case because the chances of residual after SBRT is going to be very, very high. And of course, if it is more than child B7, it is a contraindication. If you have tumors which are more, definitely will not do tumor for more. If it is more than 6 centimeters, I'll be very, very careful. But ultimately it boils down to this. You may have 2 or 3 small ones. You have 1 large one. Whether you have been able to get 15 gray to the 700 cc or not, that is the crucial thing. And these are the constants. As I told you, the 700 cc liver should be receiving less than 15 gray. The spinal cord dose 18 gray. This is a 5 fraction dose. And the V15 should be 35 gray. Of all of which, this is the most important. And the REEP dose should not be more than 30 gray. All these things are variable. The standard guideline for this to follow the UK SEBR guideline. UK SEBR guideline is very, very good and helpful. There are lots of phase 2 trials. All of them, they will show you, excellent outcome of 18 months 67%, 1 year 80%, 2 year 86%, 2 year 86%, 2 year 92%, such outcomes. And the same thing continues. One big review article this is possibly one of the best review articles from a multi-institutional research patient registry, which had shown, and this is what we all the time quote, that you have 1 year of 82% local control and 1 year of 74% survival. This is of course a combination of the chemotherapy that goes with it and not because of the radiation alone. But it basically tells you the case that is chosen. So that is the same one where they have shown a medial local regional control of 52 months and overall survival of 22 months. So that's it. It is one of the best non-surgical treatment options available, comparable to other locally ablative therapy like RFA. It is non-invasive, stringently eligibility criteria has to be employed, excellent 1 year control with no grade 3 or grade 5 toxicity. Resection is still a gold standard, but otherwise for patients who are not resectable, SBRT is safe, well tolerated, efficacious and alternative treatment. Thank you.